Well, hello everyone. I'm Lucilla Pizzo. I'm a recently graduated fellow from ARUP Laboratories and the University of Utah, and I'm a 1-month-old medical director there. Thank you, the organizing committee, for accepting our work to be presented today, and thank you all for staying to the last session. And today we wanted to talk about what we believe is a high clinical value of the use of SNP-array in the diagnosis and surveillance of inherited bone marrow failure syndromes. So inherited bone marrow failure syndromes are caused by germline variants in genes that are involving key pathways associated with hematopoiesis, ribosome assembly, and genomic instability. Some of these conditions include Diamond-Blackfan anemia, include Fanconi anemia, Shwachman-Diamond syndrome. And the molecular defect leads to a decreased cellular fitness, so a decrease or an altered growth rate and survival, and predisposes to malignant transformation. And somatic mosaicism is actually characteristic of some of these type of conditions. And it can lead to two very distinct clinical outcomes. One option is that it leads to an uncontrolled proliferative advantage, so resulting in a malignant clonal evolution and so a malignant transformation. And the other very distinct clinical scenario is that it would lead to a somatic genetic rescue, so a compensatory rescue of the germline variant, either by the loss or modification of this genetic mutation. And this would lead to a shift in cell fitness towards normal. And this is known, again, as somatic genetic rescue. So here I'm showing you different types of inherited bone marrow failure syndromes and the genetic type of modifications that can occur to lead to either somatic genetic rescue or malignant transformation. And several of these molecular alterations can actually be identified by SNP-array. For example, variants associated with malignant transformation can include copy-neutral loss of heterozygosity that overlap with pathogenic variants in TP53, deletion 7q or monosomy 7, and those associated with somatic genetic rescue can also be identified by SNP-array, such as CNLOH overlapping the gene that carries the germline variant. And this would lead to the loss of the pathogenic variant and duplication of the wild-type allele. There are other also CNVs that can be present in this somatic genetic rescue, such as isochromosome 7q or deletion 20q in Shwachman-Diamond syndrome. So we wanted to look at our data and actually show the relevance of the use of SNP-array in understanding the monitoring of this type of conditions. So we looked at our findings from an encounter of 100 pediatric or young adults with inherited bone marrow failure syndromes tested at our institution. So 30% of the cases presented at least one abnormal finding. This involved approximately 60 tests. And out of those 60 tests, 14 also presented in parallel chromosome bone marrow or FISH at our institution. So here I'm showing you a pie chart that shows the breakdown of abnormalities per condition. And as you can see here, Shwachman-Diamond syndrome is the condition that presented most of the abnormal findings, followed by aplastic anemia, SAMD9, SAMD9L related syndromes, and Diamond-Blackfan anemia. There was a slight male bias, and the median age for testing was 11 years old. So I'm going to show you the summary of findings or abnormal findings in two categories. First, we're going to talk about those that were present associated with somatic genetic rescue. So in 50% of the abnormal findings presented a pattern consistent with somatic genetic rescue, and isolated CNLOH was actually present in 40% of the cases. Some of these findings were, for example, 7q CNLOH in patients with Shwachman-Diamond syndrome and variants in SBDS gene that is actually located in 7q. 7q-LOH in patients with SAMD9 or SAMD9L associated syndromes, as a case you can see here on the plots on the right, which also are located in 7q. And more rare cases of Diamond-Blackfan anemia with germline variants in RPS7 and RPS19 with CNLOH in 2p or 19q respectively. Copy number variants were also present, but in less percentage, in 10% of these abnormal cases with somatic genetic rescue. And some examples actually involve variants that are recurrent present in Shwachman-Diamond syndrome, such as isochromosome 7q, where there's actually a duplication very frequently of a hypomorphic allele, or deletion 20q, that is actually an indirect way of rescue by altering a gene that is belonging to the same pathway where the germline variant is acting. So next, we wanted to show you a case that was actually a very good learning case for us. That it was a 9-year-old female with Diamond-Blackfan anemia with a germline pathogenic variant in RPS19, and it was transfusion-dependent, presented iron overload. So you can see here the whole genome SNP results. We see a homogeneous copy number of 2 across the whole genome, and you can see a splitting pattern in chromosome 19, on the long arm of chromosome 19. And if we zoom in further, we can see that this pattern is not homogeneous. We see increasing levels of loss of heterozygosity that is maximum where the gene RPS19 that carries the germline variant is present at 19q13.2. So how do we interpret this in the context of somatic genetic rescue? So Diamond-Blackfan anemia is an autosomal dominant disorder, and in this case would be caused by a germline variant in RPS19. So we would have 1 chromosome with a variant allele or 1 chromosome with a wild-type allele. So we would interpret this finding in the context of somatic genetic rescue as multiple overlapping clones that underwent UPD. We have the chromosome that carried initially the pathogenic variant, and now we have the wild-type allele, and the highest level of loss of heterozygosity would be overlapping with RPS19, and in this case measured at 70%. So this actually, UPD19q in cases with RPS19 germline variants had been reported before. And as I'm showing you here in this case, it was a 29-year-old that presented spontaneous remission by an increased abundance of these clones at 29 years old. So how do we integrate all this information in our reports? So, well, we mentioned that there were continuous levels of loss of heterozygosity that were maximum at 70% and overlapping where the gene RPS19 is located, and that was consistent with UPD19q, and that the mechanism, as I mentioned before, is related with rescue of the initial pathogenic variant and has been reported to lead to remission. And importantly, for a recommendation, we tell our providers that these findings should be followed up by a SNP-based array because this copy-neutral variant cannot be identified by chromosomes or by FISH. So the good news for us to hear is actually after talking with our collaborators that this patient actually became transfusion independent, so it seems to be going in a good clinical course and potentially achieving remission. So what are the learning lessons for us from this case? So we learned how to measure, interpret, and report clonal burden when there are multiple existing overlapping clones that are consistent with one unique mechanism. So now the second half, I wanted to share with you our findings associated with malignant transformation. So we have 40 out of the 30 abnormal cases that presented a profile consistent with malignant transformation, and some examples are CNLOH17P in a case with TP53 tier 1 variant in an SES case, or monosomy 7 in 3 cases with SAMD9 or SAMD9L related syndromes. As I'm showing you in that plot, this patient had a SAMD9L germline variant and monosomy 7 at 85% in the bone marrow. And this is actually a very interesting and kind of challenging finding to interpret, as these genes are located on 7q, and actually loss of 1 copy of chromosome 7 has been reported as an attempt to lead to somatic genetic rescue, but as we all know, monosomy 7 in the presence of additional oncogenic hits will lead to a leukemic clone. So definitely this was classified as a malignant transformation type of finding. And then the second case that we also wanted to share with you is a case with copy-neutral LOH in a patient with Shwachman-Diamond syndrome. So this patient was tested initially in June 2022 in a peripheral blood sample with a myeloid NGS panel that identified a tier 1 variant in TP53 at a VAF of 16%. And 1 year later, this patient actually presented the same variant at an increased VAF of now 38%. Concurrent SNP array in the same sample type, so peripheral blood, as you can see there, showed CNLOH in 17p overlapping the gene TP53 at 35 to 40%. And some of our providers are also submitting to us bone marrow in parallel, and we can see again the same finding and now present at 55 to 60%. So putting together all the pieces of this puzzle, we see tier 1 variants and the presence of CNLOH 17p, which is highly suggestive of a presence of biallelic variants in TP53. And this is very relevant for monitoring these patients and led to bone marrow transplant in April 2022. And finally, this patient showed a normal array. And what you can see up here is that in our reports, we are including, even for normal findings, we're highlighting to our providers that this individual was normal for recurrent findings associated with that specific condition and the germline variants so recurrent secondary abnormalities present in associated with a specific gene. So in regards of Shwachman-Diamond syndrome, the presence of biallelic variants in TP53 are relevant, as most myeloid malignancies in patients with SCS present with biallelic TP53 variants. And experts in the group have shown that the molecular surveillance may enhance detection of incipient malignancies and indicate when bone marrow transplant may be most effective. So for us, the lessons from this case were first to show the monitoring strategy of combined SNP array and myeloid NGS and how this helped to lead to management decisions. And second, how to uniform quantify CNLOH across different time points, across different sample types, how to link reports and build templates to include recurrent findings. So I hope that with this information, we were able to show you that we believe that SNP array can help in disease surveillance and holds promise for personalized therapy and stratification in bone marrow failure syndromes. Our learning experience has shown how to do a uniform quantification of CNLOH across different time points, different sample types, bone marrow versus peripheral blood, how to link reports, and how to generate templates to include the presence or absence of recurrent finding for a specific condition and gene. How to measure, interpret, and report clonal burden when there are multiple overlapping clones that are consistent with one mechanism, but also when there are different clones, some of them indicated of malignant transformation or others of somatic genetic rescue. And finally, the relevance for us as a reference lab to communicate with the provider to get additional orthogonal testing. In some situations, having parallel FISH was very important for us to increase the diagnostic yield. So we believe that there's a need to develop expertise for accurate diagnosis and reporting of this type of conditions. These type of conditions are very challenging to interpret because the same finding in one clinical scenario can mean something completely different in another condition. So with that, I want to thank the medical director team that is working in this project from the Cytogenetics and Genomic Microarray at the RUP Laboratories and the University of Utah, our collaborators, Dr. Lodarsky, Sarah Lewis from St. Jude's, and our collaborator, Dr. Shimamura from Boston Children's, and thank you very much for your attention.
Okay, we have time for one very quick question.
Thank you very much. Yeah, my question is about, when you nicely described how those, once it enters into malignant transformation, what kind of clonal abnormalities that you detect. But what about pre-transformation? So obviously you have a longitudinal data to follow these patients, and did you actually see recurrent clonal abnormalities just for bone marrow failure syndromes themselves before transformation?
Right. So, we're working with our collaborators from St. Jude's and Boston Children's, who are actually, the experts in the biological interpretation of these findings. There are some findings that it seems very interesting, for example, for Shwachman-Diamond syndrome, that biallelic TP53 variants can be present years before actually they end up developing a malignant transformation. And they're actually thinking of more precise technologies, sequencing technologies to identify these clones ahead of actually presenting, a clinical transformation. So it's a very challenging field still, as you all know, in development, and our findings we're seeing that are relevant to actually not only the clinical outcome, but also research information that can soon potentially transform in, clinical information.
All right, please join us in thanking our speakers.